Hi to everybody out there on our big screen sitting in front of me. I'm Neil Londa. I'm a registered dietitian, certified diabetes educator, and we're going to talk today about pumps and glucose meters and CGMs, continuous glucose monitors. I'm a pediatric. I work in pediatric endocrinology with Dr. Eckert at Renown as a dietitian. Also diabetes educator, and then we're just going to go around and introduce ourselves, and it would be helpful if you all introduced yourselves as well. So go ahead.
I'm Kathy Eckert. I'm a pediatric endocrinologist.
I'm Steve Graybar. I'm a clinical psychologist and work here at the medical school at the Department of Psychiatry.
And then let's go to Skylar.
My name is Taylor. I'm an RN with the Elko County School District.
Great, thanks for joining us. And B. Shanks. I'll take you off mute just a second. Go ahead.
Hi, I'm Bobby Shanks. I'm the school nurse coordinator with Elko County School District.
Great, thanks for joining us. And Dr. Stage.
Hi, I'm Danielle Stage. I'm a pediatrician in Reno at Community Health Alliance.
All right, that's
Cool. So it sounds like we have a couple school nurses on, which is awesome in case you have any specific questions. I think for all of us, the more conversation we have, the better it is for us. And we want to address whatever interests you have. And so sort of surrounding pumps and CGMs and meters, but you're certainly welcome to ask us any specific questions that you have as we go along. Sound good? Does anyone have anything specific that they wanted to ask? So I can head in that direction?
Or any cases that we can do at the end as well, diabetes or otherwise. Feel free to let us know.
Yeah. So if you have anything, let us know so we don't go over time. We want to make sure we give enough time for that stuff too. All right, so here we go. So meters and pumps and CGMs, oh my, which is my funny way of referencing the Wizard of Oz, because this is kind of like a little trip to Oz. All right, so go ahead. Do I go forward?
Yeah.
Okay, cool. All right, so we'll talk about blood glucose meters, certainly one of the most important parts, right, of monitoring blood sugar. Aside from making sure you're taking your insulin, we also want to know what your blood sugar is. There's currently 88 meters on the market, and that was as of a couple months ago, so that's probably higher than that now. I think there's 1 million meters out there. Certainly sort of big business because someone needs to be checking their blood sugars. We work in pediatric endocrinology, so typically lots of type 1s who are checking their blood sugars a minimum of 4 times a day. And so they can go through tons of meters. It's typically the meter that someone's put on is insurance driven. So whatever their insurance is going to cover is what we want to give them. The meters themselves aren't expensive. We typically have meters that we can give out. It's the strips that are so expensive. Things to consider when you're handing out meters, just ease of use. On the next one of the slides, I'll show you sort of the blood sample size. But in the 20 years that I've done this, the sample sizes are so much smaller. You can get away with using so much less blood, which is a big, huge deal for someone who's poking their fingers, you know, upwards of 5 or 6 times a day. Some of them have illuminated screens. All of them store results, and they can store as much as 400 and 500 results, which is a little bit excessive, but it's nice if we can get at least 2 weeks worth of readings saved. Some of them you'll hear about alternative test siting. So people always come in and ask, so can I check on my arm or on some other part of their body? We say no, that you always want to use your finger because you're going to get a more accurate reading. The requirements for blood glucose meters with the FDA is that they must be within 20% of a lab value if it's over 75 and within 15 points of a lab value if it's less than 75. So of course, looking for more accuracy for a lower blood sugar. 20% is a pretty big significant amount. So if you're talking about the difference between 100 and 80 It's pretty big. So people are always saying that their meter, if they check on one finger and then check another finger, that they've got 2 different readings. So we're looking for about 20% between the two. So blood drop size, just to give you an idea, most of the meters use 0.3, so it's a really small amount of blood that goes on that strip. It's pretty amazing. It seems like a little bit more than that, but most of the meters we use in the office are about 0.3. Tips for checking blood sugars. You always want to make sure that your patients or students are washing their hands. It's best to wash with warm water. That seems to help the blood get to the fingertips a little bit better. Super important that they're drying their hands. We have a lot of kids who won't dry their hands completely and on purpose, so that it sort of dilutes the blood. Kids come up with all kinds of cool things to make their blood sugar look better than it actually is. And so watching that they're drying their hands is a big one. I've also had kids spit into, this is awesome, spit into their Lancet device. Like there's almost like a little, in that, yeah, you know, it's like sort of, I don't know, like a well, yeah. And so they'll literally like turn their back to us in the appointment, spit into it, so that when the Lancet comes out, it's possibly not as high a blood sugar. So I would watch for spitters and for wet hands. Yep. Of course, we always want to avoid the center of the fingers. Important, I think too, if you're at a school with a kid that's checking, almost anytime I watch a kid check their blood sugar, I find something that they could do maybe a little bit better. So one is making sure that they're poking on the side of their finger. It hurts a lot less. And then also really dialing down the Lancet device. People tend to really crank up the depth that that's going to poke you with, and they really don't need to. You need such a small amount of blood that I would dial that all the way down. I can almost always get blood out of a kid on the lowest setting. Kids have really soft fingers. And that can save them, because if it hurts to poke your finger a million times a day, then they're not going to do it. So those are really small things I think that can make a huge, giant difference just in their everyday life. Changing out the needle. Technically, you should change it out every time. The biggest thing is that the needle's just going to get dull, right, every time you poke. And so that's going to also obviously cause more pain. We also have kids try out lots of different Lancet devices. People feel really close to their Lancet device, whichever one it is that they pick. And so they don't have to use the Lancet device that comes with the meter. So we'll mix and match those a lot too. So if that's kind of a simple thing too, if a kid's just not checking their blood sugar a lot, it's possible using a different Lancet device, dialing that number down, showing them where to poke. All of those things are going to help with their compliance. You think of anything else? No.
Make sure they're not checking their cat or dog's
Oh.
blood sugar.
Yeah, which is, well, yeah, I think that's on another slide too. Yeah. Stuff to watch when you're reviewing meters. So as a practitioner who's looking at the meters, make sure that time and date is accurate. Sounds really silly, but so much of the time we're starting to analyze blood sugars and they're at the wrong time. So were you really checking at 3 in the morning? Sometimes we have them checking at 3 in the morning, but that was actually 3 p.m. after school, or it could just be 2 or 3 hours off, which is just a pain. So making sure that the date and time is accurate on the meter just makes things go so much more smoothly. Is the patient washing their hands? Yesterday I had a kid that got up between 5 and 8 in the morning and ate a type 1, ate a quart of ice cream without anybody knowing. Next morning, mom gets up, pokes his finger, and he was over 600. She gave him a correction, and an hour later, he was 180. It dropped really fast. Blood sugar dropped really fast. But one of my concerns was, did they wash his hands before he poked? Because if this kid was just like going in and like voraciously eating this quart of ice cream, was he going to have just sugar all over his fingers? And we were now correcting. You're correcting for an inaccurate number anyway, because he just had that ice cream coming into his system. But that was one of the first things I thought was there ice cream still all over his hands? So watch, they're washing their hands, are they drying their hands? Do all the readings belong to the patient? Because parents and families and kids will poke each other. And so sometimes I've had readings that are making me that feel like they're too low, but it's because it's someone else in the family. So just ask them, they'll forget to tell you, so just ask them those things. And then are all the readings blood sugar? Because we have had families will put wine into the strips just to test wine, they'll test orange juice, they'll just put various liquids in there, and so they forget to tell you that they're doing that. Meter downloads, I tried to just take a quick shot of sort of what a download looks like. If you have the capacity or the capabilities to download any of the meters that you're looking at, it's really helpful to see. On the cover screen, on the cover page, you'll usually have how many readings per day they're doing. This is actually a teenage boy who's a type 1, but he's checking about 1.2 readings per day, so much less than he should be. And then it'll give you a high and a low. I think on that, for that, the thing I'm looking at most is how many, sort of the average of how many times they're checking in a day. And using that more as a way of showing parents that they're not checking. Because you'll have days where they're checking all the time and then days when they're not checking at all, so it's an average. And then you can look just sort of day by day. We usually look at about 2 weeks at a time to analyze sort of the trends, what's going on. You can see, on this one, the most recent, I think he was in the office on 11/16, so he had checked once that morning. The day before, I had checked one time. Looks like he had a 92 on Saturday, probably 8 then, and then was checking a couple hours later because he was freaking out about it. But in general, this is somebody that tends to go most of the day without checking, and then sometimes he'll have more checks just later in the day. This isn't a good example of that, but he'll check more. So sort of what a download looks like. You can see a high on this meter is over 500, on some meters high if it's over 600. I think last time you guys looked at some logs too.
The only other thing I would comment on with regards to this, and maybe you'll touch on it too, but it's always a big surprise to the parents when we show them these downloads, and because they think Johnny's checking, 8 times a day or something. And my point is about that is they have the capability fairly easily to upload these to Luco and other means of either printing it out or even just looking at the meter. And most of the time our families just don't.
Mm-hmm.
Maybe you can help us understand that.
Yeah, I think most of the time what happens is parents are saying, "Did you check your blood sugar?" from the other room, and then the kid says, "Yep, what was it?" And they say, 221 or 120, it's always 120. But the parents don't ever actually go back to look. I think probably one of the most discouraging things for me is we have so much more technology. I've been a dietitian for 20 years now, and I think we have so much more technology and so much more means to watch and to help us, and it's used very rarely. Parents usually don't download the kids' blood sugars at all. They have no idea, other than calling from the other room that, "Did you check?" And they say yes, and they're completely surprised at appointments that they haven't checked. Can you say anything to that?
Well, I mean, it's understandable. People want, I think it's hard for people to really conceptualize what chronic disease means and what its implications are. And we're used to taking medications and being done and moving on. This is not that way. Having all this technology, you still need to be willing to use it. So we try and encourage parents, one parent in a very non-judgmental, non-public, excitable way to go through one evening a week, to go through a week and to see what's been happening. And this would never happen if you did that once a week, that the kid would test 1.2 times a day on average. But it's hard, and it's hard for kids, it's hard for families to wrap their heads around the relentless grind of type 1 diabetes in childhood. So I get it. I mean, I absolutely get what they're struggling with. And yet it's also sort of mind-blowing given how incredible the technology is based as little as 15 years ago.
Yeah. There, I always think it's more interesting to include sort of anecdotal stuff. But I had a patient yesterday who's in his second admission for DKA. I think he's 12 years old. Family is very smart, very capable, but not checking. He had an admission maybe 3 months ago where we identified that dad was asking, are you checking your blood sugars? He has a Dexcom, but the child wasn't. He has a continuous glucose monitor, but nobody's checking to make sure that he's calibrating it, which we'll talk about in a little while. But I was really sort of stunned because I thought after that last DKA that that would change, but it's only been, I think, 3 months, and sort of the same patterns have happened again. So we had the psychologist go in to the room, and sort of the things that the dad was saying and the child were saying. Dad said the kid gets super defensive anytime anybody asks him about his diabetes. The child was saying, clearly the child is struggling way more than anybody has sort of, I think, recognized. He's like a really smart kid and pretty resilient and sort of plays his cards close to the vest. So I think he's probably in a lot more sort of emotional turmoil than we thought he was. So hopefully that will be addressed, but I was surprised. Oh, so dad said he gets really angry if we ask him what his blood sugars were. Child said that he's sort of on this group text, 2 households. He's on this group text with new stepmom, dad, mom, and they're all texting him, asking him his blood sugars. And so they really need to identify sort of a better way to do that because it wasn't working for him. Yeah.
Well, typically, like, excuse me, a better person.
Right.
One individual.
One person. Mm-hmm.
That can tolerate the swings and ups and downs of his blood sugars.
Yeah, and he doesn't feel so defensive too, because I think there's usually a parent, right? Even with my own kids, there's like one of my kids that I'm gonna trigger more than the other. So like identifying the person that isn't in a threatening way, checking in. Okay, so continuous glucose monitor. So that's sort of briefly about meters. Continuous glucose monitors, really the one that everybody uses is the Dexcom, and it's the G5. And I brought, so you can sort of see, there's 3 parts to the Dexcom. It reads blood sugars every 5 minutes. So the awesome thing about this is if you are checking a blood sugar, you check a blood sugar and it's 150, obviously you know what the blood sugar is at that moment in time, and it's gonna be different in 10 seconds. The continuous glucose monitor you wear for 7 days, and it'll allow you to see which direction the blood sugar is moving. So 120 is great, but is it 120 staying steady, 120 going straight up, or in worst case scenario, 120 dropping like a brick? So it's gonna read blood sugar every 5 minutes, allows the user to see which direction it's moving and the rate at which the blood sugar is moving. There's 3 parts. There's a sensor. The sensor is changed out every 7 days. I think that Troy's gonna help me see it. So the sensor is the sort of the purple part. If you look under back here, there's like a really thin wire. It's almost like a hair, and that sits under the skin. So that is what's changed out every 7 days. So that goes under the skin. A transmitter is snapped into the sensor, and the transmitter is usually good for about 2 to 3 months. And then it's sent, the information is sent to a receiver, which can be the receiver that it comes with, or it can be your phone, which is cool. The latest model of the Dexcom, you can actually see the blood sugars on your phone. So I'm gonna try to pull up the app so you can see a little bit of what it looks like. So the best part of this, especially for kids, is that parents, the info is uploaded to the cloud from the child's phone that's reading his blood sugar, and then people can follow blood sugar. So it looks sort of like this, but you'll have a bottom line and a high line, and then the blood sugars go up and down in between there. Sensors changed every 7 days, transmitter lasts 3 months. Your receiver can be a cell phone, which is best in pediatrics because then somebody else can follow to see where the child is. Private insurance will usually pay for the system and the monthly supplies, hopefully. Unfortunately, we don't seem to get it covered if somebody's on Medicaid or Medicare. But parents, spouses, and caregivers can follow blood sugars. Biggest thing that we're seeing lately with this, as I talked about with that other child, is that kids aren't calibrating. You still need to do finger pokes every 12 hours so that you can calibrate and make sure that you're getting a really nice correlation between a finger poke and the what the Dexcom reading is. And people just start to trust those numbers. And we've had Dexcoms that read in the 200s and kids who come in DKA in the 500s and 600s. Then we are able to download the data, and there it says a physician's office. You can download the data off of the receiver. The parents can do that also. So I spend a fair amount of time showing parents how they can access the data. They don't need to wait 3 months to find out that the kid's not calibrating. So just some pictures to sort of show you. You can see how sort of thin the wire is. It is kind of like a wire, but it's not stiff like a wire is. I've worn it many times and it's pretty darn comfortable. The adhesive is probably the trickiest part. We have just sort of tips for keeping the adhesive on, but if you're wearing it for 7 days, it can start to kind of raise. So we have sort of things that we can do for that. Off to the right is the inserter, so you can sort of see how that works. A needle goes into the skin, comes back out, leaves behind the sensor. And then that big, the big arm just sort of comes off. Transmitter is snapped into the sensor, and then you can see the receivers off to the side. It used to be that you had to have, the person who's wearing it had to have an iPhone on them, but now there's some Android phones that will act as the receiver, but the kid does have to have a phone on them in order for parents to follow. So that's kind of the big thing there. And then they have to have Wi-Fi connection at all times.
Could you speak to the studies that have been done that show differences in control? And again, studies are going to be different than what our population is.
Mm-hmm.
And then also the costs associated with it if it's not covered by insurance.
Mm-hmm. So I believe the system itself is between $3,000 and $5,000. Does that sound right too? Yeah, it's really expensive. And then the monthly supplies, so in theory, each sensor you're gonna wear for about 7 days. So a box of supplies is 4 sensors, and those can cost several $100s.
But the provider buys the sensor, or the monitor and everything, buys the unit, and then they just give it out to the patients.
So the families own it, so they have to apply, go through their insurance, and their durable medical person has to get approved, and then they receive the receiver, hopefully 2 transmitters every 3 months, and then 3 boxes of sensors.
Okay, so it's the family's got it.
Yeah, they have to do all of that. I mean, we help them.
Does Medicaid cover it?
No, like we're working in that direction. It seems like it's going in that direction, but I feel like I've been told that for like 2 years now, that any day now we're going to be able to get Medicaid patients covered. But I mean, we have Medicaid patients with kids with type 1 who are less than 2 years old, and it's incredibly hard to predict how much a 2-year-old is going to eat, right? And how active they're going to be and how much insulin they need. You're giving fractions of a unit, you're writing really high numbers a lot of the time out of safety, and so to me, it's not an extravagance. It should be just standard that everybody have one. It's kind of frustrating. And the new one that's been approved, I think now, the Libre. I saw yesterday, I think the sensor's $75. It's much less expensive. And then supplies $150 for a month's worth. So much more affordable to buy out of pocket than the Dexcom is. So we'll see how that all pans out. But we have, I think, 1 patient that I know of, possibly 2, who are on a Libre that they got in Europe and have brought back. But I just don't have that much experience with them. If you're looking at Dexcom reports or things that you want to look at, first you want to make sure that the patient is actually calibrating. Less than 2 calibrations per 24-hour period isn't good, and more calibrations is not better. So sometimes you have, right, the patients that are constantly calibrating, and that's not a good thing either. Patients need to be told and reminded that they should calibrate when blood sugar is stable. I think these are really good things for those who are working in the schools to know too, just kind of reminding kids, because I say this all the time and they still forget. You want to always try to calibrate when the blood sugar is stable, when the arrow is going straight across. Otherwise, we're constantly trying to hit a moving target. So if the blood sugar is rising or falling, you're not going to get a good correlation. The FDA, as of like last February, I think it was, I should say January because my kids say February really weird. As of last January, the FDA says that it's okay to use a Dexcom reading to calculate doses. So rather than a kid having to, at school, for example, at lunch, poke their finger and check their blood sugar to calculate their doses, they can go ahead and use the Dexcom reading. Here in Washoe County, we'll sometimes not let the kids do that if they haven't been calibrating regularly. Sometimes we have parents who still want their kids to poke their finger. I think I'd probably still get a finger poke if it was up to me. You can use the Dexcom to your advantage to sort of watch those rises and falls, but I would still want a number to calibrate or to calculate a dose. Would you?
Yes.
Probably, yeah. You want to advise the patient to confirm with the finger stick if the blood sugar is over 350-ish or 80-ish. So if they have a high or a low on the Dexcom, go ahead and try to correlate. Try to check a finger stick also, because those are, numbers you're treating. We also want to check the blood sugar with a finger stick if the symptoms don't match the Dexcom reading. So if the kid is feeling weird and the Dexcom says they're 200, which feels is normal for them, they still want to check. One of the things, so you have the families that don't check and don't calibrate and aren't getting close correlations, and then you have the families who are obsessively calibrating and poking and freaking out about postprandial excursions. So it's interesting when you wear a Dexcom, and I've done this too, so you wear it and then you go drink a Bloody Mary and eat 2 waffles to see what happens to your blood sugar.
Do you want to talk about that?
It's pretty startling how high your blood sugar goes. And so now I have a pancreas that in theory works pretty well. So parents will see that a kid starts out, even if they're starting out at 200, they might go up to 400 in the next hour, and that freaks them out, and they want to give corrections. They want to do something about those numbers. And so a lot of times we just have to remind them, like, to sit tight. We want that blood sugar to come back down within the next 4 hours or so. Insulin is still active in their body. We just need to caution them about trying to correct those really high numbers. Dexcom reports, they look like, sort of shows average glucose standard deviations. You'll see the calibrations up in the right-hand corner. It says average calibrations 2.1 per day, so it's pretty good. On this particular person, I just grabbed, I actually grabbed some of it. It's pretty good. So you can see that the calibrations are pretty steady at like 9 in the morning and 9 at night. This is, on Monday, that's just a loss of connection. I think that's when they came in for their appointment and we disconnected it. But this actually is, if you think about who it is, actually really pretty good control. The bottom line looks like it's set at 80, and the top line is set at 150, which is really close. Yeah, usually I'm thinking about school too. So I've had parents who will put the high alert on 200, and then the Dexcom's beeping all the time. We know a kid's gonna rise, even a couple hundred points after they eat, and so you don't want to unnecessarily stress everybody out by having beeping going off. So I'll usually set the high end, possibly above 300. All right, so insulin pumps. So I was asked, why does a patient want to pump? And their first answer is, I don't have to carry so much stuff, which isn't true. You actually have to carry more when you're on an insulin pump than you do on multiple daily injections, because we ask you to carry everything you would normally carry on MDI, plus all of the stuff that you need to do a site change in case your site goes bad. It'll be less work. People think it's going to be a lot easier. They're going to have a lot better control. And then with kids, it's because so-and-so had it at camp. Like everybody has this pump at camp or at their meetings. So we usually try to like vet out like who's going to do best. I have really strong feelings that the people that do best on pumps are the ones that have spent time figuring out how to get really great control on multiple daily injections. I feel like those that have really great grasp on that are the ones that do best on pumps. I feel that it's not a good idea to start a pump too quickly or when somebody's in their honeymoon phase, because they get away with quite a bit more in the honeymoon phase, and I've had starting a pump coincide with the honeymoon phase ending, and it just sets up for a bad relationship with the pump. They think that the pump, everything changed when they went on the pump. So we usually try to be careful about that. Can you think of any other big things?
You know, just dispelling the rumors that it's going to be a piece of cake on a pump, because a lot of people do think that they don't have to watch anything anymore. This is parents, I mean, and children are just not able to do all of this by themselves.
Yeah, I think it's almost easier for parents to not be as involved when a kid's on a pump because the kid's sort of pushing all the buttons and doing everything. So it's probably easier to be unaware of what's going on. Scary. But I think in our practice, all the practitioners feel that a pump's a privilege and not a right. You know, certainly other practices do it differently where they start on pumps right away. I think in pediatrics too, and especially with teenagers, pumps can be like a pretty good carrot to dangle in front of somebody. Is that a good technique?
Well, I just, about pumps, so much are about fantasies of what pumps can do. And we've had, and oftentimes I remember we had parents, one parent would be pushing a pump fanatically. And it was usually the uninvolved parent who really didn't understand what that meant. And okay, it was usually the dads who wanted the pump, and it was buying just a whole different venue of problems.
Yeah.
Or unanticipated problems, because they're just hoping that the pump actually, it's sort of misnamed almost. You know, it sounds like it's going to be an artificial pancreas.
Right.
And it's just not.
Yeah.
So then there's a big letdown and another failure for the kid and for the family, and it's really too bad, actually. I think you guys do it the way you guys have always done it has been great, to not give into that kind of pressure. And there was always a lot, as I recall.
Yeah. Sometimes it's good too because you can say, so here are the things, here are the 3 things that we want you to do in order to get a pump, and then we start kind of chipping away at what those things are. Yeah, I mean, I guess I have patients too that have sort of pulled their stuff together so that they can get the pump, and then it goes sideways pretty quickly after. So you have that happen too. And I have lots of kids who do fine on the pump but just don't like it. They go off of it in the summer, or I have one girl yesterday who I thought was a perfect pump candidate for years, and she was completely not interested at all in doing it. And she's now been on for about 6 months, and she said it was life-changing. And her mom said, and you were resistant for all those years. And I was like, wait.
Wisely so.
Yeah, it worked because it was the right time for them. So I think that's why it's been such a good experience. She's doing awesome.
And to that point, you know, like Steve was saying, there are a lot of parents who want the pump and the child is not into it at all, and it won't work. We can pretty much guarantee it will not work. Unless we're talking about a toddler or a preschool child, you know, these older kids after age 5 or so, if they're not into it, it's just not gonna work at all. So we don't recommend that they do it.
Yeah. I have like another family, so the high school son has had diabetes for a while and has no interest in a pump. Little brother was diagnosed and wanted to be on a pump within 6 months. And the little brother's probably 6th grade, and the older brother's probably a junior in high school. And I thought it might turn the older brother around. Not at all. No interest whatsoever. And it's just not for everybody. We take pumps away too. So if people aren't doing what they need to be doing, if we feel that they're not safe, then taking pumps away. Happens too, and it's not fun. We tend to see 3 different pumps in our office. To give you a little overview of each: the Medtronic, the Omnipod, and the Tandem tslim. So a little bit of information about them. The Medtronic, the 670G system it's a system because it has a CGM that comes with it. But this is what you'll hear about most on the news and articles, is being called an artificial pancreas, which I don't consider it to be, and I think you probably don't either. I mean, that gives, like Steve was saying, that gives the sense that it does everything on its own. What the 670G does is it can make really small changes to the basal rate based on what the sensor says. So Medtronic has their own sensor. They don't use a Dexcom, they have their own sensor. And then it's supposed to sort of get to know your body and then make small changes. So if you're rising or falling, it can make changes. None of that is approved using that microbolusing and the adjustment for patients it's under 14. And so we don't really have anyone right now using those features. One thing that I would say too is if it's making changes based on what the sensor says, I would want to trust the sensor a lot, right? And so if we are saying that even with Dexcoms that people don't necessarily use their sensors appropriately, it makes me a little bit nervous that a pump is making decisions based on a sensor that may not be used correctly. Yeah. There's the auto mode you can read says that it automatically adjusts the basal insulin levels every 5 minutes. That being said, I've talked to adults who are on it who are super happy and think it's amazing. So that's all really good. Definitely exciting stuff for changing. Omnipod brought a PDM, but forgot the pod. So all of the pumps are going to deliver insulin, and they're going to deliver insulin in hundreds of a unit, really small increments. So in theory, that can give us much better control, because rather than waiting to give 2 units or 3 units, we can give 1.252 units. So that can give us better control. So they all basically do the same thing, but I'll sort of highlight the differences between them. So the Omnipod is the only one that is tubeless. The other pumps are going to feed through a tube that goes from the device into your skin. So with the Omnipod, you wear a little pod on your arm or on your legs or on your abdomen. It houses the insulin inside of it. So then you have a PDM that you use to tell the pod your blood sugar and for it to send to give you insulin. So it's the only one that's tubeless. You have the PDM to bolus. It holds 200 units of insulin. The Omnipod's great because it is tubeless, so little kids can go swimming with it on and not worry about it stopping. It's still going to give the basal rate while they're doing all of those activities. One of the things that I make sure people consider is that it holds 200 units of insulin. The other pumps hold 300 or 450 units of insulin. Everything has to be changed out at least every 3 days. So sometimes someone will pick a pump that holds 300 units because they can go 3 days without changing it. The girl I was talking about yesterday, she has to change it every 2 days, but is super happy, does not want to have wires. So I was telling Troy before, it's kind of like picking between a Mac and a PC, iPhone and an Android. I don't have any sort of guess as to what people are going to pick. So I try to just highlight the things that are different. The PDM uses 2 AAA batteries, so that can be a consideration that you have to have batteries on you all the time, which speaks to carrying more stuff with you. You have to use at least 85 units in it. So I think this model is attractive for really little guys because parents can hold the PDM, have control, bolus their kid while he's within 5 feet across the room. But the pod itself is kind of big, so it can be hard to find a good spot to put it on. The catheter and the needle are inside the pod, so the catheter gets inserted. And so that's one option. We also have kids who don't use more than maybe 2 or 3 units in a day. And so there's a fair amount of insulin waste. Though the PDM is also a meter too, so that can be, you can cut carrying out one extra thing there. And then the last one's the Tandem, the tslim. It's the only pump that has a touch screen. It's the only one that's rechargeable, so that could be, I mean, that's something I point out to people, that you can recharge it versus carrying batteries. That's a make it or break it for some people. Holding 300 units, or if it has a model that holds 450 units, can be a deal breaker versus 200 on the Omnipod. The Tandem pairs with the Dexcom, so you're using Dexcom technology to see your blood sugars on the pump itself. And then one of the cool things with this too is that the latest model, the software updates can happen from home. So traditionally you've had to get a whole new pump if there was a new model. The tslim is actually, you can plug it in at home and update the software so that you get the new features after you've had your pump. Sort of that looks like, so that's a tslim with the G5 that you can look at your blood sugars on your tslim or on the phone. Most people are still going to opt to look at it on the phone so that parents and families can follow up blood sugars. I think that's it. Any questions? I guess I'm curious too, for those that are at schools, what you see in terms of any of them, uses with meters or issues you come into contact with meters or CGMs or pumps.
This is Bobby in Elko. Can you hear me okay?
Yeah.
So over Christmas break, I think we had 3 students come back with the tslim and the Dexcom G5.
Merry Christmas.
I know. We didn't know they were coming either, so it was kind of a surprise. But you know, I know we have some parents that are struggling with those postprandial highs. How soon do you, or how long would you like them to wait before they correct? Because I think some of the parents are confused with, do I correct? It says 250 at 9 o'clock, and then they're correcting, and then they're dropping low. I think we see that sometimes with them getting used to the pumps and their CGMs.
So with the pump, it'll reverse correct too, so you have sort of that target range in it. You have your insulin on board, right? So it does that for you, but we really don't want anybody to give a correction, you know, under normal circumstances, 4 hours apart. Sometimes we'll have people do insulin every 2 hours if they have ketones and they're higher, but I really try to have families just hang tight and watch that it's going to come down in the next 4 hours or so.
Okay.
I think too that if they start sort of overriding, because you can override function right on the tslim, like you can decide to give more or less insulin than what it's suggesting. But the families that tend to do that, then we never quite get a good handle on what the actual doses should be.
Right.
So as I tell them, I kind of try to hang tight and just do what you're supposed to do. That way we can make adjustments to the rates, and that's what's going to give you the better control overall. But when they're constantly sort of overriding or guessing or adjusting at the beginning, then we don't get a good read. But yeah, they see those highs and they freak out, right?
Yeah, you know, and then the other thing we do too is, I think when the parents first start watching it on their phone, we get the frantic phone calls, you know, she's 200 with a double arrow down. You need to give her something. I'm like, well, 200. Should we wait a little bit?
Yeah.
What kind of guidelines do you typically give parents on those, you know? Do you wait a little bit to see how low it's going to go, or do you?
If they have an arrow going straight down and they're 200, I would wait, maybe wait a little while, or give them some kind of protein to see if you can blunt that drop.
Right, okay.
Obviously wouldn't let them go long enough so that they have a low that has to be treated. But I think throwing some protein in there can be helpful.
Okay.
What do you say?
And also you have to take into account the context of when that's happening relative to insulin and food and maybe exercise.
Sure.
Because if they exercised 2 hours ago, they may have initially gone up in their blood sugar, and now they're starting to come back down as their resistance decreases from the exercise. So it's, I mean, when you look at the technology, it seems like pretty cut and dry, right? There's a down arrow and it's 200 and you need to give more food, but you always have to take into account so many other things to understand or try to understand why it's happening. And that's the tricky part.
Yep. Yeah, that's what we see too.
Especially with the young kids, because you don't know exactly what they had for lunch. And they might have told you one thing and had another and took insulin for X, but ate Y, so. And then went out to recess and played really hard this day, but yesterday really didn't.
Right.
So it's really variable.
Yeah, I try to assure parents too, we're trying to drive between the lanes, but we don't have to drive right in the center. You're going to we just want to keep sort of the barriers on the side, but you're going to go up and down within there. But try to help with that too. They usually ask, how long has it been since they last took insulin, what they ate, and just sit tight, let's sit tight a little bit. But that tends to be when it's really high or just high and it seems to be hanging out there. I mean, there's some advanced features too, so you can, if there's a food that they eat that they always just stay high for a while after, which is typically pizza or sometimes I hear sushi, pasta in general, then you can do that extended bolus. So I'll try to work with parents on figuring out how to use that. So it gives the first of insulin up front, and then you can decide what percentage to give up front and what percentage to give over the next 2 hours, the next hour. And that can sometimes help when it's really high. But again, that's a parent that's paid pretty darn close attention. Those are like awesome features that they're excited about that they never really use.
Cool. And then the other thing too, you mentioned the doing a finger stick between 80 and 350.
Above 350 or below 80.
And so we were doing some research, and there was an ADA statement that talked about following up with a finger stick if it's below 70 or above 250.
Mm-hmm. Yeah, there was a little bit different, the numbers. In the hospital too, I think they teach 75 and 300. Those are the numbers I feel good about is 80 because I like it a little bit higher.
Okay.
But your school orders are probably pretty specific.
Well, we're developing them kind of for the G5 right now.
Okay.
So, for Elko, where it's kind of different because we have patients who come to your office. We have some in Boise, Twin Falls, Salt Lake. So it's hard to get
every office
consensus. Yeah.
Is going to do things a little bit differently. I think the Washoe County school orders, which is obviously what we do, we see the most of, say either 300 or 350. I think it's 350 and 80.
Okay.
Yeah.
And if we're going to err, I would always err on the conservative side. So, because we don't want it to be confusing or difficult on your end to have these orders. So if someone out there saying, hey, we like that at 70 and 250, we'll find that. It's better to check more and be more responsive than to be less, of course. So, so we're not going to be sticklers about stuff like that either.
We have parents on both sides of the vote, some who are good with following up with finger sticks and some who say, no, we don't have to do a finger stick except to calibrate ever again. And that's like, well, no, we probably need to do a few.
Yeah. Yeah, the school orders, I say hours, but the school orders for Washoe County say we can say yes or no to using a Dexcom to calculate meals, doses, and we change those, sometimes say yes and then take it back and say no because they're not calibrating.
Okay. That's a good point.
Yeah, so you can have it. It's always hard because then the school orders just get longer and longer and more confusing, I think, in some ways, but
yeah. And I don't want that. I don't want, 6 pages of orders. I want it simple, but to include everything.
Right.
Cool. Thank you.
Yeah. Thank you for sort of confirming. I think what I thought probably happens is that you have some parents who just freak out and see those numbers and they're calling you.
Yeah, that was a phone call this morning right before the.
And you guys are already back in school. We still have 2 more weeks off, or I guess 1 more week.
Yeah, we're back in school.
Yeah.
One other comment just about that particular scenario. It's pretty unusual to have a really rapid drop in a blood sugar. I mean, short of significant exercise, or maybe you just ate some food and then you threw it up and you've taken insulin. But even with that, it's not usually a rapid drop. And so to Yolanda's point, waiting and just rechecking 10 minutes later or so, I think is very reasonable. And the scenario that she gave earlier with the kid eating a bunch of ice cream, we don't really know what that number was. We don't know either of those numbers really, how accurate they are, and therein lies a big problem, So I actually spoke with that family last night about midnight because they were so concerned about his blood sugar being 130 when he went to bed, and what Lantus dose do they give? So, rightfully so. And then this kid is recently diagnosed as well, so they're neophytes when it comes to all this. And so, they were just checking him every 2 hours or so, and really, really nervous. And again, understandably, but my point to them was, we don't really understand exactly what happened that morning. It probably wasn't the insulin that they gave him necessarily. It may have been differences in blood sugar readings, but also you have to take into account when someone's in the honeymoon period, they're making a lot of insulin themselves. And that part, just to throw another bugger into the whole equation, that one is really, really hard to tease out as well.
Yeah, and the child has autism and ADHD, and so it's hard for him to sort of tell us what he's feeling or what happened. So that made it really tricky, but he had dropped from 600 to like 180 in an hour. And so we were really nervous that he was going to continue. So he came into the office where we fed him for the next 2.5 hours and checked blood sugars every 15 minutes, which was probably a really good call because I think he went down to like 130 or so. It was stressful. I'm sorry that it came back to a call last night.
That's okay. It's my job.
Can you think and Steve would talk about this for sure, but we always say too that you throw type 1 into like the most stable of families that have great circumstances and great support systems, and it'll throw them for an absolute loop. You throw type 1 at somebody who doesn't have a really stable household or has any sort of other things, medical conditions going on in the families or other diagnosis, and it's really, really hard.
I agree. We see that a lot.
Mm-hmm.
The only other point I would just reinforce is, with technology in so many areas and specific to diabetes, we have fantastic opportunities. But as Yolanda pointed out earlier, unless you're using it, not even to its fullest extent, but to a small extent even, it doesn't do us any good. And in fact, sometimes it does more harm than good. It really is. So we have to be very, very careful with who we choose to put on these different pumps and CGMs and so on. Okay? It's not a cure-all, unfortunately.
Yeah, I think I've been most bummed about the Dexcom lately, that we've had so many kids not calibrating and ending up in DKA, because I feel like with the Dexcom, its only purpose is to make life better for you. And so to somehow find a way to use it against you is really, really frustrating for me.
Are there any questions or cases that anybody wants to present today? Okay.
I think the other thing I wanted to ask real quick is that anything else that you would want covered in the future that you want to hear more about that would be helpful?
I think as there's more technologies or new devices coming out or new ways to manage, those are always really helpful to try and stay abreast of the latest trends. Yeah. That's really helpful.
There's a lot to keep up with, for sure. Yeah.
There is.
Yeah.
I appreciate you being on too, because I think that sometimes we don't have quite as much communication as we could, and we could, understand a little bit more about what's happening in the office and what's happening at school is really, that's only going to help us.
Great. Yeah, I agree. Thanks.
Mm-hmm.
So next month, we're going to do the 4th of the diabetes installments, and that will be with the three of us, but I think Steve Grabar will take a bigger role, and we're going to discuss psychological and behavioral issues, as well as some comorbidities, including eating disorders associated with diabetes, and so on. So hope you can attend that one as well.
Great, thank you.
Thank
Sure.
you.
Thank you. Bye.